Oh, thank you. And I've been in Yorkshire at Leeds for about 20 years at the liver unit here. So what I've been asked to talk about is something to do with the medicines that we use in children with liver disease. And obviously that's a ginormous subject, so I can't possibly do all of the medicines that we use and all of the different considerations that we have. But from a quick straw poll of some of our general paediatricians here, and thinking about the sorts of questions that I get asked fairly regularly, the things that I've thought to talk about today. Oh, my screen has frozen again. That's going to get annoying. Sorry about this. It was freezing a bit earlier and it's doing it again. Anyway, hopefully it'll go.
Penny, if you don't have animations, then you could just take it off presentation mode and just magnify the viewer mode on PowerPoint if that is more effective.
Okay. Yeah. I'll do it like that. So can you still see that screen?
Yeah, if you press the plus button in the bottom right corner, just so it magnifies it a bit, then we can make the most of it.
Yeah. Oh, yeah. Yeah, okay, that kind of works, doesn't it? It's not quite as good, but it'll do. So the topics that, oh, that's still not quite right. Let me try and move the screen. There we go. So, like I say, the areas that seem to come up the most frequently relate to how you choose the most appropriate medicine for a child who's got liver impairment. And that can be liver impairment for whatever reason, maybe an underlying liver disease, but also children whose liver function goes off because they're septic or they've had some gastric surgery or something like that. So all sorts of different reasons for LFTs to go off. Cholestatic liver disease is probably one of the things that commonly causes admissions into general pediatrics, often for cholangitis or for other reasons. And the drugs that we use in cholestatic liver disease, it's really just to explain what some of those are and why we use them. And then recently I've had a few questions about choice of drugs for bleeding varices. And so just to highlight the protocols that have been agreed between the 3 liver centres, so that's King's, Birmingham and Leeds, about the treatment for bleeding varices. And then I'm very happy after that to talk about anything else that anybody would like to. And if you have questions, feel free to stick something in the chat and I'll try and keep a vague eye on that. Or just shout up, because I'm very happy to be interrupted and can answer hopefully any of your questions. So the topic that I probably get asked most about is choosing medicines for patients with liver impairment. And I think there's a slight misconception about what the question really is. I often get asked, well, it's about metabolism, and if a drug is metabolized by the liver, then obviously you can't use it in a liver patient. But actually, there's a whole lot more to drug handling than just metabolism, and it's everything about drug handling that can be impacted by liver dysfunction. So we're just going to talk a little bit about the pharmacokinetics and those aspects of drug handling and what liver impairment can affect. Another thing that's important actually is if the drug is safe to use in a liver patient. And there's lots of situations where actually you might think it's handled well, it's not metabolized by the liver, but actually it's not safe to use, maybe because it causes bleeding or some other side effect that could be harmful. I get asked, how do I find all this information? And of course, there aren't any very good sources. We don't have nice equations like renal do for calculating creatinine clearance, so we have to use other methods, and often that means thinking more in first principles about what we would do. And a question that I get asked an awful lot is which analgesic can be used in a liver patient. And actually what I would like you to do is to choose out of paracetamol and ibuprofen which drug you think would be safer or better to use in a liver patient. Scribble it down or make a mental note or put something in the chat if you like, if you're prepared to commit. And we'll talk about that a little bit as we go through and hopefully bust one or two myths. So when we talk about drug handling, we're really talking about all of the different pharmacokinetic parameters, so absorption, distribution, metabolism, and elimination. And actually, there's also a little bit about pharmacodynamics, although I'm not really going to touch on that. But things, all of these different aspects of how a drug is handled can be affected by liver impairment. Some of this is all very anecdotal, and it's from our experience of managing liver patients rather than what's written in any textbooks. So ascites, for example, we know that when we give frusemide orally to a patient with really bad ascites, that they don't seem to have a diuresis. But when we give it IV, they do. So anecdotally, we know that ascites can impair absorption, certainly of diuretics, and therefore probably of other things. And I suspect that's just because the gut gets boggy as part of the acidic picture. Absorption may be affected by cholestasis. So if you're very cholestatic, then you don't excrete your bile salts into your gut, so you're going to have impaired absorption of fat, and that then includes fat-soluble drugs. The fat-soluble vitamins are the obvious ones. We know that we need to give massive doses of the fat-soluble vitamins, and that children with cholestatic liver disease can be very cachectic, fail to thrive because of their fat malabsorption. So we know we need to give bigger doses of fat-soluble drugs, and there are all kinds of drugs that are fat-soluble, and we'll talk about one or two of them. Well, certainly one as we go further through the talk. When we think about distribution, that's where the drug is going in your body, and ascites is going to have quite a significant effect on water-soluble drugs, because suddenly you've given a much bigger water volume to a patient. So you're actually going to need bigger doses per kilo, particularly of things like gentamicin, which is highly water soluble, in order to get adequate levels to achieve your MIC. And it's something that requires really careful monitoring. So maybe daily levels for something like gentamicin or vancomycin when you've got someone with ascites, because if your ascites suddenly goes down again because you've given diuretics or you've done a paracentesis, then actually you suddenly need to give a lower dose or you'll have high levels. So it requires sort of really careful monitoring. Drugs that are highly protein bound will have more free drug in patients who are cirrhotic, who are very end stage liver disease, because they're likely to have low albumins, and that means you'll have less protein for the drug to bind to, and so more free drug, and consequently higher, much higher risk of side effects to those drugs. In our failure to thrive patients, then we may well have a reduced volume of distribution for lipid-bound drugs, because actually the child doesn't have much fat in their body, and so you need smaller doses per kilo, because otherwise there'll be more free drug in the blood. Metabolism is the thing that people latch onto, and actually it's a slight misnomer that it's the most worrying thing. Metabolism is pretty well preserved in liver patients. So even the cirrhotic patient, cirrhosis being a continuum really of early cirrhosis, when you have a very compensated liver function and you have enough hepatocytes to do all of the normal metabolic functions that we would expect, and that includes metabolizing drugs. And although we can't measure that very easily, we can look at other things related to synthetic function to determine whether a patient is likely to be able to metabolize. Our problem comes as people get further down the cirrhosis continuum and they have got a decompensated cirrhotic picture. And in that situation, they may have a coagulopathy or encephalopathy. And then at that point, we know, because they're having these other consequences of cirrhosis, that actually they probably no longer have enough functioning hepatocytes to metabolize drugs. So it's only really in that group where you have a decompensated cirrhosis that we need to start worrying about metabolism of drugs. Acute liver failure would be the other situation where metabolism may be impaired. And that's, when you're talking about somebody with an ALT that shot up to a few thousand. So in those situations, we need to think about reducing the dose or increasing the interval. And that depends very much on the drug and how it's handled, and whether it's a peak level that you need or it's just going to take a long time to clear. The other thing that can be affected in a cirrhotic patient is, obviously, when you have cirrhosis, you increase the risk, or you're highly likely to have portal hypertension. And a number of drugs undergo first pass metabolism, which basically is where the drug is absorbed in the gut early on, goes through the portal vein straight into the liver, where it's metabolized. And if it has a high extraction ratio with that first time it goes through the liver, then actually the amount of the drug that gets into the systemic circulation is going to be quite small. If you've got portal hypertension and varices, then you bypass the liver, because the drug goes into the portal vein and then actually is going through varices straight into the systemic circulation. And so you get high levels of drug in the blood early on. And so you need to reduce the dose, and you need to do that often quite significantly. And the most common drugs that we would be using where this is affected are morphine and propranolol. So you need to be aware of drugs with high first pass metabolism in portal hypertension. Elimination, the biliary cleared drugs may well be affected if you're cholestatic. And so if you're profoundly cholestatic, then you can't clear any biliary cleared drugs. And so you may get accumulation of those. This isn't as big a problem for most drugs as it sounds like it could be, but it's very difficult to quantify the effect of cholestasis on elimination. There's two things that are important. One is that actually you may have metabolized the drug already to something that's inactive. So it doesn't matter if you can't clear it, because it's an inactive metabolite anyway. So we're not worried. And there's also an element of a compensatory pathway that occurs where most drugs have got part biliary clearance and part renal. And if you can't clear through the biliary pathway, then we do see an increase in renal clearance. Now, it may not always be as effective as being biliary cleared, but that slight increase can just help to get rid of any drug and facilitate elimination of it. So although elimination is something that we would consider, it's often a minor concern. So the situations where we're worried are cholestasis, sometimes with absorption of fat-soluble drugs and potentially elimination of biliary cleared drugs. But more so, we're worried in patients who've got hepatocellular dysfunction. So we're worried if they've got impaired metabolism, reduced protein binding, deranged distribution, if they've got ascites, if they're encephalopathic, or they've got portal hypertension and varices. So all of those elements of hepatocellular dysfunction is where we need to focus most of our attention. And it very much depends on the severity of the liver dysfunction. We don't have, as I've said already, we don't have a nice marker like a creatinine where we can do a nice calculation to work out creatinine clearance. So actually what we have to do is look more for these surrogate markers. Where we're measuring INR and albumin, those give us an idea of what the liver's synthetic function is like. So if it's still making clotting factors and it's still making albumin, there's actually a very good chance that it's still able to fully metabolize drugs. So we probably don't need to worry. With bilirubin, you can look at the split bili and see whether you're conjugating your bilirubin normally. And again, if you're able to conjugate bilirubin, you're probably able to do some of the metabolic functions that you need to conjugate drugs. Most drugs are conjugated or oxidized or something. So the conjugation pathway, if it's still intact for bili, is probably still intact for drugs as well. If you're encephalopathic, that probably means that you're not metabolizing some of the other toxins that your liver is involved with getting rid of, and that's leading to encephalopathy. And so actually, if you're not metabolizing other toxins, then you're probably going to struggle to metabolize drugs. So encephalopathy is a good marker of when there's hepatocellular failure. And we've talked about the ascites and the portal hypertension. So those are the situations where we use surrogate markers. So those all count to build up a picture of how bad somebody's cirrhosis is. We are not worried about hepatitis or fibrosis because your hepatocyte function is pretty well preserved in those situations. The side effect profile, this is one that often gets overlooked, but actually is at least as important as the pharmacokinetics. So we need to be worried about drugs that cause GI ulceration, because if you've already got varices or you've got a coagulopathy, obviously there's a risk of bleeding. When we've got somebody or drugs that cause constipation, in cirrhosis, we know that constipation can precipitate encephalopathy. So we don't want to worsen constipation or cause constipation in a cirrhotic patient because that increases the chances of them becoming encephalopathic. Our cholestatic patients may have itch related to their cholestasis, to bile acid deposition in the skin. And so we don't want to give drugs that we know can cause pruritus as a side effect because that might just make it worse. Again, in our cirrhotic patients who are either at risk of becoming encephalopathic or who are already encephalopathic, we need to be super careful about drugs that cause sedation. And that's the obvious things, like drugs intended to cause sedation, but also things that are a bit less obvious. Like, there's the sedating antihistamines you need to be aware of, cyclizine for nausea, vomiting, that can be profoundly sedating. And we, over one weekend, inadvertently gave somebody who was an end-stage cirrhotic some cyclizine, and she was basically asleep for about 36 hours because the cyclizine just completely wiped her out. So, you know, to be a little bit thoughtful about those slightly less frequent side effects or less obvious side effects to drugs. If you're already coagulopathic, then any drug that can worsen coagulation needs to be considered. And there's a few funny ones like SSRIs that bizarrely can also cause some coagulation defects. And the coagulopathy may be related to synthetic dysfunction in a cirrhotic patient, but may also be vitamin K deficiency in a cholestatic patient. So maybe you can reverse the coagulopathy with some vitamin K and then give the drug that you want to give. But if it's a synthetic dysfunction, then no amount of vitamin K is going to make any difference to their coagulation. Again, in our cirrhotic patients, we're quite worried about electrolyte disturbances and any fluid balance disturbances because both of those can worsen encephalopathy or precipitate encephalopathy with electrolyte disturbances, or precipitate or worsen ascites if they've already got a bit of underlying ascites. So that's thinking again about things that slightly unusual side effects. Some of them will be obvious, but sometimes it's a bit less obvious. And with the electrolytes, it may be even the excipients in a drug that maybe have a high sodium content. So you need to be aware that maybe you don't want to use that drug because of the sodium content, or you want to dissolve it in dextrose instead of saline to give IV to minimize the sodium load that we're giving to somebody. And then renal toxicity is a risk in somebody who's cirrhotic just because there's a higher risk of precipitating hepatorenal syndrome. and that has worse outcomes, both in terms of their current cirrhosis, but also in terms of transplantation, if that's the way they're heading. And I haven't mentioned hepatotoxicity, but that's because that comes in a little group all by itself. I think there's an assumption that hepatotoxicity is going to be a very bad thing in somebody who's already got an underlying liver disease. But actually what we know is that you're no more likely to get an hepatotoxic reaction to a drug if you've got an underlying liver disease than if you didn't have an underlying liver disease. The only difference is that actually it's more difficult to tell whether a change in LFTs is caused by their underlying liver disease or by the drug that you've given. And so it's just being very aware of the sort of picture that you might expect from hepatotoxicity reaction with a drug, and the time frame that may happen over. And as you can see, the time frame can be huge. It can be months after you start a drug before LFTs go off for some drugs. So just being aware of what that normal picture is helps to separate out any LFT changes that are drug related or are underlying liver disease related. And there's a really good website here, the LiverTox website, which has got fantastic summaries of the drugs. It's an American website, but so some drugs aren't on it, but it has a really good summary of the picture of hepatotoxicity that you might expect, the time frame that you would expect it, and then how quickly liver functions return to normal if they do when you stop the drug. So it's a really useful website to know about if you don't already. The other problem I mentioned at the beginning is where you find information, and as I've said, there is no nice equation. So we're thinking more about those surrogate markers and just looking at the patient as a whole to determine how bad their liver function is, which bit of their liver isn't working, and what other signs and symptoms they've got of liver disease, and whether they are going to have an impact on drug handling as well. And you can find bits of information about drugs that are helpful. They won't give you an answer, but they at least alert you or provide you with some of the information that you need to help make a decision about drug handling and dosing in a patient. So the BNF tends to say things like caution in liver disease, or manufacturer recommends reducing the dose in severe liver disease or dysfunction or impairment, or maybe uses the child Pew scoring system, which isn't quite so relevant in pediatrics anyway, but so that they can't guide you that clearly about what to do. But at least if it says in the BNF caution in liver disease, that should alert you that you need to think about it a little bit. You might not have an answer, but at least you're alert. The manufacturers, so the SPC is the manufacturer's blurb, and SPCs tend to very much on the cautious side and will say it hasn't been investigated in liver dysfunction, therefore it's not recommended. And that's almost always the default position from drug companies. So that's not very helpful for us. But within the SPC, there is a section about pharmacokinetics. And when you go to that, at least you can see how it's metabolized, how it's cleared, whether it's protein bound or if it's water soluble. So you have an idea about some of that information that you might need. Failing all of those things, ask your pharmacist and they'll probably ring me. But those are our problems. So we have to go back to our first principles. We have to think about how the disease is going to affect drug handling. That's the disease or the dysfunction. So again, it might be that patient with sepsis or a hepatotoxic reaction to another drug. But also we need to think about how the drug is going to affect the patient. So I'm going to ask you again, which analgesic could you use in a patient with liver disease? And I'm only going to give you two choices, paracetamol or ibuprofen. And there's 10 of you. I don't know if, would you like to put some things in the chat and just say whether you think, which one you think would be the more appropriate drug to use in liver dysfunction? just a little bit in the chat. Oh, great. Ibuprofen. Thank you, Sophie and Max. Paracetamol film. Thank you. Any others? Oh, there's a few more coming in. Okay, great. I appreciate your involvement, your responses. Thank you. In actual fact, you can't really answer that question, because a patient with liver disease could have a bit of fatty liver and have an ALT of 100. They could have cholestasis that's mild or horrendous. They could have completely acholic stools. They could have they could be cirrhotic, or they could be just have a mild hepatitis. I'm sorry. So in actual fact, as a question, you can't really answer it. But to unpick it a little bit, oh, is it stuck again? Oh, I'm going to imagine that we've got 3 different liver patients. So one with a mild hepatitis, ALT of about 120. So this could be something like a fatty liver, or it could be someone who's had a viral infection. They've got normal INR and no signs of chronic liver disease. In a cholestatic patient, we're going to pick one who's got a bili of 90. They've got pale stools, but their LFTs are otherwise normal. And in a cirrhotic patient, where we've got a compensated cirrhosis, but on the cusp. So they've got an INR of 1.4, albumin, so it's just on the edge, albumin of 30, so again, just low. We know they've got varices, but they've got no ascites and no encephalopathy. So in these situations, we're going to think about these 2 drugs. So paracetamol is hepatically metabolized. Lots of different pathways for metabolism of paracetamol, the conjugation and oxidation. And paracetamol really only becomes toxic when you're going down this pathway. You make NAPQI as one of your oxidation metabolites, which under normal circumstances is then conjugated with glutathione to these lovely, safe metabolites that you can excrete. The problem happens when we've run out of glutathione, and that either happens in somebody who's had a paracetamol overdose, so they've used up all their glutathione, somebody who is severely malnourished, and I've certainly seen paracetamol toxicity in children who are anorexic or cachectic or on enteral feeds but poorly nourished. We see it in alcoholics as well, obviously less so in children who are alcoholic, but we certainly see it in adults who are alcoholic. And in very advanced cirrhosis, you can have low levels of glutathione. So in those situations, then you may go down this pathway to hepatotoxic reaction. But for the majority of patients, these pathways, the conjugation pathways, are adequate to do most of the metabolism. And so you really are only seeing hepatotoxicity if you overdose or you've got those malnourished or very cirrhotic patients. So in actual fact, in our paracetamol situation, in our mild hepatitis patient, yes, we can use paracetamol. Just be a little bit cautious in alcoholics, but normal dose, wouldn't be worried about it. In our cholestatic patient, again, normal dose, there's nothing to be concerned about. And in our cirrhotic patient, the one that I've given you, who's on the cusp but is compensated, then it's fine to use paracetamol, and actually it would be our drug of choice. Once we've got to decompensated cirrhosis and they're coagulopathic or encephalopathic, then I'd start to get a bit more twitchy, and I would reduce the dose to 3 times a day and perhaps stick to the 15 milligrams per kilo, not go up to 20. But it's still fine to use. And in our acute liver failure patient, again, it's fine. If they've got an ALT of several thousand, I might reduce the dose to 3 times a day. And obviously, if the reason for acute liver failure is a paracetamol overdose, then I would not give paracetamol. But basically, paracetamol is the drug of choice in a liver patient if we're taking it to a sort of nice simple levels. So please recommend paracetamol. Ibuprofen, on the other hand, has got a few things that are of concern. It's lipid soluble, so if you're cholestatic, you may have reduced absorption. It's highly protein bound, so you may have change in your volume of distribution. It is hepatically metabolized, and it's got all these side effects that we want to be a bit careful about. So GI ulceration, platelet aggregation inhibition, renal impairment, fluid retention, electrolyte abnormalities, hepatotoxicity, although rarely, but still can happen. So there's actually quite a lot about ibuprofen that should be raising a few alarm bells. So in our mild hepatitis patient, yeah, it'll be fine. And you can use it at the normal doses, and just be aware that hepatotoxicity, although it's rare, is a possibility. In our cholestatic patient, maybe reduced absorption. There's a risk about displacement of bilirubin from protein binding sites and vice versa. So there may be more free ibuprofen available, and there may be some displaced bilirubin, which can increase risks of, well, certainly in infants, of kernicterus. And in our cholestatic patient, there's a reasonable chance that they'll have some vitamin K malabsorption, and so they may have a coagulopathy, and so just check the INR before you give them any ibuprofen. So you could use it if you've checked all of those things. You just need to be a bit careful. In cirrhosis, however, I prefer it if you avoided it like the plague, for all of those reasons that we've talked about. And certainly on our unit, we've just banned ibuprofen, and that's easier. So nobody gets ibuprofen. That was to be avoided. And we have had patients admitted to us with GI bleeds because they've been recommended ibuprofen by their local hospital instead of paracetamol, and then they've presented to us with a bleed. So just a word of caution. So our key messages about when to worry are a cirrhotic patient if they're decompensated, somebody with varices because of the risk of bleeding, ascites, cholestasis, and if they've got a very low albumin, but only for highly protein-bound drugs. So I hope that was helpful. Certainly it's skipping over a topic that I could talk about for hours, but that's a flavour of the problems that we face. So I'm just going to talk now, I'm moving on a bit quickly, and I'm happy to answer any questions, but cholestatic liver disease, just because it's something that's possibly the more common type of liver disease that's seen. And children are going to be on fat-soluble vitamins and antipyretics. And the main vitamins that we're worried about obviously are A, D, E, and K. We are only really worried about vitamins if they've got chronic cholestasis. So, you know, a short-term cholestatic condition, we're probably not going to worry about. But in chronic cholestasis, we can see severe vitamin deficiencies, particularly the intrahepatic cholestatic conditions like PFIC and Alagille syndrome, where they can be profoundly cholestatic and then profoundly vitamin deficient. So we've had kids with multiple fractures or chest wall that's concave because their bones are so soft. So I'll whiz through these because I'm a bit aware of the time, but vitamin A, main problems are night blindness or another eye problems, but it also can impair immunity if you're deficient. And the choice of drugs that, well, certainly that we use in Leeds is Dalavit, and we would choose Dalavit because it's readily available in primary care as well, so it's easy for GPs to prescribe, and it contains a decent amount of vitamin A in a normal dose. And although obviously Dalavit contains other water-soluble vitamins as well, we're not worried about overdosing on those. So Dalavit would be the the vitamin A preparation of choice. There are drops available, but they're unlicensed, and so they're more difficult to get hold of. There are also capsules that are available for older children who can swallow capsules, and there is an IM preparation, although it's got pretty poor bioavailability, so we don't tend to use it unless we've got somebody who's actually properly symptomatic from vitamin A deficiency, so blind, then we would go for IM. Vitamin D, this is a bit of a busy slide, but you'll be very aware that you get your vitamin D, it's hydroxylated in the liver, but you'd need to be very, very serotic before you can't hydroxylate vitamin D. So the vast majority of liver patients are still able to do that step. And then having hydroxylated at the 25 position, you then hydroxylate it again at the 1-alpha position in the kidney. So for the nephrologists among us, that's the bit that means that for renal patients, we would give alpha calcidol, because basically you're bypassing the kidney step because it's already hydroxylated at the 1-alpha position. And then you make your active vitamin D calcitriol, the bit that's actually doing something. When we are measuring vitamin D in the lab, what we're measuring is this one, the 25 hydroxy vitamin D. Obviously, deficiency causes bone problems, and that's the thing that we're most concerned about, but vitamin D has a whole load of other roles that we're finding as we go along. And we're using vitamin D levels, but also PTH and alk-Phos as markers, as you are very aware. We do treat with cholecalciferol here. So although there's a potential malabsorption of cholecalciferol as a fat-soluble vitamin, again, we give big doses. And for our profoundly cholestatic patients, we may be giving 25,000 units 2 or 3 times a week to get adequate vitamin D levels. When that fails, then we move on to IM vitamin D. There are loads and loads of vitamin D preparation. Difficult and something that you need to be really aware of in terms of taking drug histories or prescribing, because there's so many different strengths of product out there. Vitamin E, now it's a shame this slide has come up, but vitamin E has lots of horrible side effects, and most people don't really know what vitamin E does in children. You might have a vague idea that in adults you use it because it helps your skin, makes your skin nice. But actually in children, profound vitamin E deficiency is related to neurological impairment. And we know that children who are deficient, by the time severely deficient, then by the time they're 10, are likely to be quadriplegic. So it is serious, really. And we make a lot of effort to replenish vitamin E in children who've got low levels. And that would be starting with a very low dose or standard dose of 50 milligrams. But actually some of our very severely intrahepatic cholestatic children may need doses as high as 4 grams a day, which is absolutely massive. And if on those doses we're still not getting adequate levels, then we would give it IM monthly to try and get the levels in range. And it does, any neurological problems do improve when you get the levels up. So it's worth persevering with treatment. Again, various different preparations, liquids and capsules, and the IM. Some centres are using tocophersolan, which is a pegylated version of vitamin E, and that in theory has improved absorption even in a cholestatic patient. But it's very expensive, and just at the low doses in a biggish patient, you're talking about sort of £1.5 grand a month, and often they're going to need higher doses. So it isn't something that we've used here in Leeds. We've tended to move instead towards giving IM injections. Vitamin K, there's a couple of different analogues that are used. So phytomenadione is the naturally occurring vitamin K and is fat soluble, but there is menadiol, a water soluble synthetic vitamin K that we use when the INR can't be corrected with phytomenadione orally, we would switch to menadiol. It has a fairly short half-life. We prefer phytomenadione because it also has a role in bone mineralization. And so for long-term use, we'd actually rather they have the benefits of the bone mineralization as well as the clotting. The important thing to note is that vitamin K is going to work if you're deficient because of cholestasis, but it isn't going to work if you've got a deranged INR because of your because you're cirrhotic and you've got end-stage liver failure. So no amount of vitamin K will make a difference in that situation. And INR is our surrogate marker, so you can't very easily measure vitamin K. The preparations, I don't think I've talked, oh yeah, there's the preparations, and there's a couple that are available. One is Near-K, which are these funny little capsules here where you basically snip off the end with a pair of scissors and there's liquid inside. Or there's Kanakian ampules, which GPs seem to prescribe almost first line, even though they're way more expensive and patients have got to, or parents have got to struggle with glass ampules. So I prefer the Near-K capsules as a much easier option for parents. So the main things about those vitamins is that any intercurrent infection, you invariably need to give extra doses, particularly of vitamin K. So it may be that you're seeing a child, a cholestatic patient who comes in with an infection, needs antibiotics, and actually if you check their INR, it may be 2, 2.5, and just giving well, a 1 or 2 doses of IV vitamin K will be enough to correct that. So, you know, when you get those sorts of patients admitted, please just check their INRs and give IV vitamin K. Pruritus, I'll just whiz through, but the main reason is the bile salt deposition in the skin, which can be really irritating, and that's because bile salts are basically detergents designed to solubilize fat in your diet, and it's a bit like sticking your hand in a bowl of washing up liquid and leaving it there for a week or two. Your hand would, you would be very itchy, and that's the problem that we find. We primarily want to do medical management where we can. There are surgical options if it's so bad the medical management's not working, and that may be a biliary diversion to an external stoma or an internal one. Or in the worst cases, it's actually a liver transplant, and sometimes we do transplant these children because of itch, if it's that bad, because it's absolutely life upsetting in every way. They don't sleep, they don't develop, the whole family is affected by somebody who's itching constantly, and these children really are itching absolutely constantly and looking for things to scratch up against. So what we're trying to do is anything that gets rid of any bile acids that have made it into the gut, we want to try and prevent them from being reabsorbed back into the liver so that they get excreted. Oh, don't mean to do that. We give urso to nearly everybody. It's a tertiary bile salt. It probably improves bile flow, but it isn't very good at preventing itch or treating itch. We use pretty generous doses, but it's very well tolerated. Tastes pretty disgusting because it is a bile acid, so it tastes of bile, which if you've ever been sick enough to be vomiting up bile, you'll know it tastes horrible. A much better drug for actually improving itch is cholestyramine, and that works by binding the bile acids that have made it into the gut and preventing them from being reabsorbed. And it works really well. Within a couple of days, you should see an improvement in itch. And the only problem is that it tastes utterly disgusting, and it's like eating sand. It's a sachet that you have to mix with water, although you can mix it with food, with yogurt or whatever, but it's still a really gritty, sandy product that trying to get children to take is very challenging, and although it works, our problem is compliance. Rivampicin would be our next line antipyretic, and it's probably working by getting rid of some of the colonic bacteria that convert your bile acids to bile salts and cause enterohepatic recirculation lower down in the colon. So in theory, reduces overall bile acid levels. Lots of side effects, but the red tears is one of them that we always have to warn parents about. And actually, theoretically, it's hepatotoxic. When you think about TB drugs, we automatically think of those as being hepatotoxic. In real life, with rifampicin on its own, it's extremely rare to see any hepatotoxicity. So although we keep an eye on it, it isn't something that we worry about. It is good at interacting with other medicines because it's an enzyme inducer. And then we have a few other drugs that we have up our sleeve for the more difficult to treat pyrétics. Ondansetron probably is working by inhibiting the 5-HT3 receptors, and we know that at the dermal level that 5-HT3 can be part of the itch response, and so blocking that seems to work for some children. Quite small doses. Going back to our drug use, it can cause constipation, so a bit careful if you've also got cirrhosis or risk of encephalopathy. But small doses for some children is effective. And then naltrexone. So we know that opioids cause itch. So using opioid antagonists, which naltrexone is an oral opioid antagonist, does seem to work. Now, the only problem we have is that it causes tachyphylaxis, or it exhibits tachyphylaxis. So you start with a nice dose, it works absolutely wonderfully, and then after 4 or 5 days, maybe 5 or 6, it stops working, and so you have to increase the dose. And you increase it a bit, it works brilliantly for another 5 or 6 days, and then it stops working, so you increase again, and we go up in steps, eventually getting to a point where actually we're going to get more side effects from the naltrexone than we want, and so we would stop. So what naltrexone offers us really is just a short-term relief from itching, and maybe if somebody's had some intercurrent infection and their itch has got a lot worse, then naltrexone can give you some relief. Or if the family are about to kill each other because the itching is driving the whole family mad, then we might try a naltrexone course for a month or 2 to see if that helps. And some families, the whole family gets relief, and for some children that relief seems to last even when we've stopped the naltrexone. That relief continues for a little while longer. Fortunately, in the pipeline are these ileal bile acid transporter inhibitors, which in the ileum are blocking the transport pump that is responsible for the recirculation of bile acids earlier on in the gut. And these are in the process of going through NICE at the moment, so I suspect will be out in the next year-ish, hopefully, because they look very promising. And then the last thing I was going to mention was just about esophageal varices, because we get asked about it quite a lot or asked for advice. And there's a full protocol on the Bespagan website, which is a protocol agreed by the 3 liver centres, so again, King's, Birmingham and Leeds. And basically, it's octreotide is our drug of choice. It works by causing vasoconstriction and reducing the bleeding. And we have a very standard way of administering octreotide. It's got a really short half-life, so it's important that once it's started, it doesn't get stopped, because if you stop it suddenly, you can get rebound bleeding. And we would give a loading dose and then a maintenance dose, which we wean slowly once the bleeding has stopped over 24, 36 hours. And ideally, these children need referring to a liver unit for OGD and either sclerotherapy or banding of those varices. But octreotide is something that you can start immediately in your own centres. So I feel like I've whizzed through that lot. There's a lot to talk about, but I am very happy to take any questions